Thanks for coming in. Let me.
John and Mary.
John and Mary.
Millie.
Mary used to be an OR nurse.
No, I'm still an OR
She's
nurse.
still an OR.
Once an OR nurse, always
Always
an
an
OR
OR
nurse, right?
I'm retiring next year.
Wow, good for you. Good for you. Well, I want to take you through what the system looks like, what the components are, and then if there's questions about value or where everything is applicable, that's great. Also want to have an opportunity for you to stick your head in the console and move some instruments around just to give you a feel for what it actually feels like and what the concept is behind the technology. So to start off, what this is set up as is essentially a dual console system. So if this were completely installed into an operating room, you could have two operating consoles, one for teaching or like if you were in a residency situation, a resident operating on one console, the surgeon operating on another, so that they could pass instrumentation back and forth, and that teaching surgeon could ensure that it was safe surgery while allowing the resident to practice the craft. What this is set up as today is our second console is actually a simulator. So if anybody wants to actually get a chance to play on the simulation device, what it will allow you to do is practice in between patient care. So if you have a gap in between surgery, you can sit on the simulator and you can just get used to continue to stay fluid and moving the arms, moving the cameras, clutching, keeping your wrists fluid, and just do some simple practice to allow you to stay proficient in between patients while you're not necessarily using the device. What we have installed in Palmdale is essentially these three components. So the surgeon console is where the surgeon sits during surgery. All of the instruments, the cameras, the energy, everything is fired directly from that console. Now when your head is submersed in that actual console, instead of looking at a 2D screen like you see on the tower, you're actually in a 3D high definition environment. So what it allows you to do is to have more depth of perception on the anatomy. What you can see is magnified by 10 times the magnification. So even those small bleeds, you'll be able to respond to and correct immediately. So it's neat. This is essentially like a laparoscopic tower. All of the brains are functioning right through this tower. So from generators to fire a vessel sealing device and a stapler, all of the primary brains are functioning here, essentially operating through the computer. So everything's computerized. You place the computer in between the surgeon and the patient. Here, they can telestrate off of this screen and they can see it inside of the surgeon console. So if the surgeon's saying, hey, I'm in the middle of this procedure, I can't find the ureter, do you see where the ureter is? Yeah, the ureter's right here. And then the surgeon can see within where that anatomy is. This is the actual patient card, so the operating arms of the system. What this allows for the surgeon to do is have essentially 3 operating arms at any given time. So they can operate 2 hands at once and have a third arm retracting tissue, as well as having total control over the camera. You can see that the camera doesn't move. If I were doing a laparoscopic surgery traditionally, the way they've done it for years, I would have one of these. I would be holding onto a camera, and most likely it would look like what you're looking at here. And I'd be doing this, and I'd have my hand in here, and it would be shaking around a little bit. So when I'm able to do this, and I'll have you sit down and actually get a chance to move it, the camera is completely stable at all times. When you move it, you press down the pedal, you move it where you want it, you release the pedal, and the camera will stay totally secure. The instrumentation is also designed to filter out tremor through the technology to allow that to be a more stable instrument. The core technology of the instrument really is about the 3D high definition vision and the wrists on the instruments. So what you're allowed is basically 540 degrees of freedom. I can rotate these instruments, I can bend my wrists, I can open the jaws, and my hands are basically shrunk down to about a 5mm instrument. Cool. When I replace that, one of the safety mechanisms that's actually built into this, and I'll actually demonstrate it. When you're exchanging instruments in a laparoscopic procedure, you take an instrument out, you reintroduce an instrument. If that instrument's reintroduced too quickly, you could potentially go in and create damage internally, right? So what the system is designed to do, since it's computerized, is when I remove an instrument at my bedside and my assistant is going to replace that instrument, they essentially attach it. When this is flashing green and white, all I do is press on the back of this and it will stop not even looking, about 2 millimeters short of where I initially had that instrument. So there's no risk of going too far and puncturing a bowel or creating some sort of wound. So it's all built for safety. Now, the other piece is all these cannulas. When you're doing a laparoscopic surgery, especially if you need to get access somewhere else, you're doing a lot of levering on the muscle layer and the tissue. So if I want to go up and left, I've got to go down and right, and I'm creating torque on that muscle tissue, which is why a lot of times people have that pain on port sites. So the way the technology is designed is that these little black lines, which are introduced into the muscle layer, are axillary. So if that were my muscle layer, no matter what direction I move this instrument, or how hard or how far, it doesn't cause any torque on that tissue, so I have less pain. Make sense? Who wants to sit down? Move things around. Anybody? Go ahead. So what you can do with the surgeon console is actually adjust it to wherever you're comfortable. I can lower this armrest for you to rest comfortably when you're actually in the operating environment. I can move the headrest up or down and tilt it back or forth to make it more comfortable for you while you're operating. The foot pedals will also slide back and forth depending on how long your legs are. Okay, so if we're comfortable, these are the master controllers. So when you put your fingers in the master controllers, what I would do is take your middle finger and your thumb. So put middle finger there, thumb there, leave your index finger free on both master controllers. Now when your head goes across this infrared line, the system will sense that and you'll be able to gain control of your instruments. If your head is outside of there, it'll recognize you're not in there, all the instruments will freeze. So if you had to turn your head to talk to somebody in the operating room, the instruments stop. They won't move until you are back in that console doing what you need to do.
Well, what if a surgeon wears glasses?
It's okay.
You leave the glasses on.
So go ahead and lean forward if it's comfortable. Now just pinch and release your fingers and rotate your hands a little bit. And you gain control. Same thing with your right. So you have both hands you can operate with. So go ahead and get control of your right hand as well.
The right's not moving.
Release your hand a little bit. Just relax. And go ahead and go ahead.
There it goes.
There you go.
What are they doing?
Well, sometimes if you grip it too hard, it won't respond. So you want to grip it nice and easy. It doesn't require a lot of strength. As you reach down, you can grab a hold of any of these rubber bands. Now you're in a 3D environment. If you were doing this in 2D, you'd be doing it without the depth perception. So reaching down and grabbing that little red rubber band down there would be a little bit difficult. So go ahead and reach out and grab a hold of it.
There you go.
Once you have a hold of it, you can open up your hands nice and wide. Now you can grab that with your left hand too. Use both hands. Wrist. Go ahead and turn your wrists, because that's a big piece of the technology. Is that when the surgeons learn laparoscopy and want to offer minimally invasive surgery, they have to give up certain things. They give up their 3D vision because they're looking on a tower like this. They give up their wrist and the ability to really wrist and articulate around tissue. And they also have to learn that backwards thought process of down and right is up and left in order to be able to do this.
You got it, girl. Look at that.
You're ready to go.
Higher.
So if you can imagine, if you had a long surgery, depending on the type of surgery you're doing, being able to sit in a comfortable environment, your third case, your fourth case, you're not any more tired than you were on your first. Patient number 3 gets your best just like number 4 gets your best.
So I understand they're doing more and more different surgeries now with the DaVinci.
Yeah, so our instrumentation over the last few years has changed a lot. So, in the beginning, we thought we were going to be a cardiac company. We started off in prostates. That's really where things launched. We also have a stapling device. It's just now becoming available where you can staple from there with a wrist. So doing colon surgery, being able to right angle across the colon while you're doing your staple line and not have to worry about crossing staples or getting bad angles. This stuff is starting to make it a bigger deal. And we also have a single port access now. So for gallbladders, for example, you can do a gallbladder surgery using the robot through one incision in or around the belly button. So a 2.5 centimeter incision with our port. The granular, designed to allow the instruments to triangulate back on the anatomy, just like you would be doing regular laparoscopy, only you can do it with one incision. So this technology right now has been approved for gallbladders initially. It's been like that for probably about a year to 18 months. And just recently for simple benign GYN surgery.
Right, yeah,
so
I
that's
understand.
we're just now getting started. We have a few surgeons in California that are kind of launching it for us, and just people who have a lot of experience, people who we trust to be able to manage it appropriately. And once we learn from it and see how things look, then we can start looking at what surgeons are appropriate to train to offer.
So if you're doing a cholecystectomy, you're going to remove the...
gallbladder right through the port.
Yeah.
Just
Wouldn't
pull
you
in
have-
right behind.
Yeah, but wouldn't you have to make the incision a little bit larger depending on
So,
stones in the...
well, it depends on the size of the gallbladder. So sure, I mean, you know, when you do the initial incision with this single site kit, we tell you about a 2.5 centimeter incision, and that'll allow you to insert the port appropriately and get access. Now, when you're removing the gallbladder, typically that size of an incision, the good thing is it's a made incision as opposed to just like a wrench to tear open more faster than pull, and then you have a herniation risk because you tore, as opposed to just a nice cut that's sutured easily. So if you have to extend, I haven't seen many people have to extend, but it could happen, certainly, depending on the disease. But yeah, I mean, it's
That's amazing.
generally you can pull right through the hysterectomy. So now that we have the instrumentation to be able to suture, we'll start to see that become more and more prevalent here, hopefully not too distant future. Just getting started.
Wow.
Now, what does a versatile machine like this cost? Of course, when you're laying on the operating table, you want the very best there is. So,
cost is variable because there's
Of all
different
the-
ways to configure the system.
right,
There's different types of cameras that we can put on. There's different types of instruments.
sure.
And things that we include. I mean, it's really highly variable.
Is there a starting ballpark,
It's
$1.5 to $3 million?
I wouldn't say that high. I'd say you could probably guess that $1.5 million is pretty close. It just depends.
Yeah,
It depends on how what the hospital needs for technology.
sure.
And so that we can help construct what it is that's appropriate for them.
And the average time it takes a surgeon to train on it? I mean,
So we have a pretty defined training protocol for surgeons, but a lot of that
Sure.
is defined by the hospital as well.
sure.
They do have to spend time in the lab, being able to show proficiency on the equipment. Really, the point is how long to proficiency, and that's just a matter of being on it and doing it consistently.
Sure. And you've spent your whole life kind of in this area. What do you think of this piece of
I think it's
equipment?
amazing.
Truly?
Yes.
Uh-huh.
Yes.
And you've been in the operating room, and you've...
Yes, since about 1981.
1981.
Yeah, I've seen a lot of...
Well, you must have picked up one or two things in that time.
I've seen a lot of changes in that time.
Yeah. So this, you feel, would be a great boost for this hospital and the people in the Antelope Valley.
Absolutely.
Well, sir, you were saying that USC for urology procedures now is using this system. And
They're one of the most advanced programs in the world, actually, in the use of the DaVinci robot in urological procedures.
yes,
And it's really fascinating to go down and watch those procedures at USC. But they're a leader, and we are happy that we have the ability to work with hospitals and organizations like USC.
sure. And you were saying the operation, the procedure's the same, but this is a different way of doing it, essentially.
Correct. In fact,
Yeah.
I would have Mike Cameron, who's our
Sure.
Director of Business Development, who actually has a surgical background, explain it a little better than I would as a layperson.
And you have a surgical background. Well, that'll be great.
Yeah, I ran the surgical programs at Cedars-Sinai Medical Center and some at UCLA. My name is Michael Cambron, C-A-M-B as in boy, R-O-N.
Yes.
And the advantages to the DaVinci are multiple. Some of them are related to smaller incision sites, fewer incision sites, and it has the ability to transilluminate. In other words, to be able to see the vessels that are through the tissue at the time of surgery, so they don't inadvertently cut a blood vessel or nerve or any other devices. Or any other, not devices, but with this device,
Sure.
they don't run into vessels and stuff like that. They're able to protect the patient, and the outcome and recovery is about a day or two shorter than is typical with the traditional methods.
Marvelous.
It's very similar to laparoscopic, but the robot allows one less surgeon to be involved in the care because they can place it and control the robot to move the tissue around
Oh, I see.
and safely place it. So there's less reliance on personnel, so it's better for the physician practice as well.
Sure,
because they
sure.
can spend time in clinic or rounding in the hospital and taking care of patients.
Yeah, yeah. And a system like this has a lot of bells and whistles or enhancements, but what generally is the ballpark cost for our hospital of putting this in?
It's variable, but it can be anywhere from about $1.5 million to about $2.5 million, depending on all the whistles and bells that you might want.
Sure.
And so each medical staff will determine the needs of the organization. So this lends itself to women's health in terms of gynecology. Mm-hmm. It works for bariatrics, for people that have excessive weight and they have to have not a tummy tuck, that's different, but where they're having their stomach not stapled, but kind of wrapped. And that reduces the ability to eat a lot.
Yeah.
They can do that with this machine here. It also works for ENT, for base of the tongue cancers.
Oh, yeah.
It can be used in the chest for lungs. There are centers in the United States that are doing this for open heart surgery.
Oh, really?
And it's also good for general surgery, for gallbladder, so you can preserve, you don't have to injure the liver or any of the structures, all the blood vessels that go in there. It works well in a colorectal cancer, and its number one use where it came into the market was for urology and prostate surgery.
Oh, yeah.
Because the prostate's located so low in the pelvis
Right.
that it always took 2 or 3 surgeons to do it. And now they can do it with one surgeon who sit there because of these retractors, and they can do a much smaller incision, and people go home in a couple of days versus used to be a week. When I first came into this field, it was 7 to 10 days people stayed in the hospital
Wow.
when they had their prostate removed.
Yeah.
But not
Yeah.
anymore.
Not anymore.
So the hospital, in terms of a cost-benefit analysis,
Yeah.
we look at it lower blood loss,
Yeah.
lower length of stay,
Yeah.
physician satisfier.
Sure.
Patients are happy because it's a smaller incision, so they're not out as long.
Sure.
It's fewer physicians in the community are needed.
Yeah.
There's such a shortage looming. That's very important to us. And then it also provides us with an ability to go to the payers and demonstrate to our community that we're a minimally invasive
Yeah.
center. We do the least invasive type of surgery on the patients because they get the best outcomes with the best cost savings and benefit in that regards.
Sure.
And the hospital makes a little more money by getting people out sooner, but we are at the whim of the doctors. If the doctor says they stay, we support 100%. If the doctors say they can go home tomorrow, we'll help the patient to go home tomorrow. But if they're uncomfortable and want to stay a little bit longer, we'll talk to the doctor and allow them to stay a little bit longer.
Sure. That's it. Let me say that. Well, that's exciting, and the sick people here in the Antelope Valley. The next question is, when is it going to be up and running?
We're going through the training process with the physicians. The doctors in our community have determined they want outside proctors, people that are experts in this technology, to come up here and monitor and train them. The doctors are going outside the area currently to get all their training.
Sure.
And some of them have already been doing this, but not with the single port, the new one that's just one incision.
Yeah.
So they're getting that additional training down in Los Angeles or up in the Bay Area. And some of them are even traveling back to the Midwest to get training because they have relationships and trust factors there.
Sure.
But we expect and anticipate sometime in September that we will be doing our first cases. The doctors have already presented us with 10 to 12 non-urgent surgical cases that are, if there is anything elective.
Sure.
But it's we're hopeful by the middle of September we'll have our first 2 under the belt.
Right. Well, I would say from the community, thanks for being forward-looking and having the courage to invest in a system like this. It seems phenomenal looking at a surgery being done that way.
Yeah. Thank you. What we want to do is really support the community. You know, the patients that are here, the people in the community, as well as the physicians and the payers who are demanding that we respond, and we are.
Yeah.
So thank you for taking the time today.
Okay, well, you're welcome. I learned something.